I'd like to also thank the organizers for inviting me. It's my first trip to Hungary, and I very much enjoyed the sampling of Hungarian wines last night, perhaps too much, but very nice. And I always seem to be given the task of talking about things that we don't know very much about, so I can pretty much say what I want, because that's how much of what's in this literature is done. It's expert opinion. And as best I can tell, an expert is somebody who writes a chapter and gets their name out, and all of a sudden they're an expert in something, whether there's much known or not. So my task is to talk a little bit about what we do know about the treatment of acute recurrent pancreatitis and chronic pancreatitis. And I was given the mandate of focusing on total pancreatectomy and auto-islet cell transplant in children. So we do know, as the first two speakers have let you know, that acute and recurrent and chronic pancreatitis are real. They're significant problems for children, which is a new understanding. We now know children do develop chronic pancreatitis, that the disease is progressive, and there is a variation in the rate of progression, and we don't have good ways to predict that. There's also variation in the clinical course. There's clearly a subpopulation that has a very impaired quality of life. They have frequent hospital admissions. They do have chronic pain that can be daily. It can prevent them from going to school. It can prevent them from doing their normal activities, their sports, music, dance, whatever they like to do. And we also know that exocrine or endocrine insufficiency can occur in childhood, so the disease can be fairly rapid. You've seen this slide already. I'm just going to, it was animated, I'm going to flip forward. And I targeted it as a progression model. We do know now, I think, that many children have discrete episodes of acute pancreatitis before they develop changes of chronic pancreatitis. And given that our sensitivity for detecting these changes is quite low. I don't mean to imply anything in this model. I think you can imagine many different ways. I've certainly seen 2-year-olds that have come like this. Their pancreas looks like that at the beginning without episodes of pancreatitis. There's some who have a few episodes before they get here. And I'm not implying that these are increased, that everything improves in between, because there probably is fibrosis that develops below our levels of detection. Is there a chronic inflammatory process that's always present and gets exacerbated during this? So we don't know anything about this model other than we know that kids can have discrete episodes of repeated episodes of acute pancreatitis, and eventually some of those kids develop chronic pancreatitis. But we really don't know the pathophysiology, and we clearly don't know the natural history of this disease in children, and that's going to be a recurrent theme. Etiology, we've gone through. We know that genetic risk factors are common. This is just a table presenting reports from different countries, the number of patients, and the percent with genetic risk factors. And these are the genes that were tested. And I realize, it's already been discussed, that the meaning of some of these is unclear and in a particular patient population. But this is the data that we have, and this is what we're dealing with. And everyone seems to agree that genetics are a strong risk factor for acute recurrent pancreatitis and chronic pancreatitis in children. There are other etiologies, as Aaliyah just said. And they include the toxic metabolic, which are oftentimes difficult to describe. Autoimmune, I think type 1 autoimmune disease in children is quite rare. It's been very difficult to pin down. We do see type 2 in association with inflammatory bowel disease, but I think it's also uncommon. There are also some children who develop severe acute pancreatitis and are left with pancreatic insufficiency. Obstructive causes and idiopathic still make up a large population. So to me, the first step in the treatment of acute pancreatitis is to look for treatable etiologies. And there are a number of those. There are metabolic etiologies, which are uncommon: hypercalcemia, hyperlipidemia, alcohol, smoking, medications. Fortunately, we don't have a lot of at least that we know about, alcohol use or associated pancreatitis in children, although it may be we don't ask enough about it. I know in some countries where binge drinking is very common in in the teenage population, they do have episodes of acute pancreatitis associated with that. Medications are important, so it's very, an important history is useful. Autoimmune, perhaps treated, I think it's very rare. Mucosal disease, and one could argue about these. I think it's unclear whether or not celiac disease is really a risk factor. Crohn's disease is clearly a risk factor. Eosinophilic disease, or actually some well-documented reports of adults who had food allergies that resulted in an eosinophilic gastroenteritis that was associated with recurrent episodes of pancreatitis. They removed the food and the thing stopped. And there's a couple where they've actually re-challenged and patients have gotten acute pancreatitis, but they're unusual. Duodenal ulcers. I've seen a couple kids who had giant duodenal ulcers who kept getting episodes of pancreatitis, and the first one I saw was actually diagnosed during the ERCP. He hadn't had an EGD before. Obstructive causes, cholelithiasis, biliary sludge, one could argue about that. Biliary anomalies, pancreas divasum, choledochal cysts, anomalous insertion of the common bile duct, annular pancreas. Duplication cysts, I've seen kids who've had duplication cysts of the stomach or duodenum present with acute recurrent pancreatitis. Tumors, fortunately rare in children, although oftentimes benign. Parasitic infections, I've seen one child with an ascaris in the ampulle that was diagnosed in an upper GI. You could actually see the GI tract of the ascaris in the, filled with contrast. So there are other things to look for, and it's very important to do a comprehensive evaluation, because that's usually, I think, our best chance of being able to stop the progression and recur acute pancreatitis. Approach, obviously, is pre-testing, a careful review of history, particularly for medicines. Physical exam can be important. First-tier investigations could include a comprehensive metabolic panel, lipid profile, serum calcium, ultrasound, CT, MRI of the abdomen. Second-tier investigations are listed here. And I think those are tailored to the patients and your suspicion. But once again, I do think that we owe it to our patients to do a very careful evaluation for treatable etiologies. So nonspecific treatment of acute recurrent and chronic pancreatitis. This is my slide on treatment. Their algorithms, I'm not a particular fan of algorithms. I think at least in the United States, they're more helpful for lawyers than they are for physicians, but that's okay. So there's medical therapy. People have proposed antioxidants. There's a little bit of data that in adults with chronic pancreatitis, it may help with pain. There may be a subset that respond. No data in children at all. The use of pancreatic enzyme replacement therapy. Really no data in adults or children that it's useful, although it's done frequently. Low-fat diet, absolutely no data. And low-fat diets, we could talk about that, but they were proposed because people didn't understand physiology. And I don't think they're necessary. And treating pain, which is probably the most common medical therapy that we have. But I think it's also important to understand that we really don't understand the mechanisms of pain in chronic or acute recurrent pancreatitis. And there may also be different subsets in pain. As David Whitcomb was talking about the other day, there's no correlation between what you can identify radiographic changes and the type of pain that someone's going to have. There are invasive therapies. So if one algorithm that I stole from Adam Slifka, who's an adult gastroenterologist at Pittsburgh, is if you look at the amylase and lipase, if they're persistently elevated, he likes to do an ERCP with sphincterotomy. I haven't been impressed that this is particularly helpful in children, but it's not been carefully studied. Patients who have episodic episodes may benefit from a cholecystectomy, even if you don't find abnormalities in the gallbladder. Once again, this has not been studied. Anecdotally, I've had a couple patients whose episodes stopped after gallbladder surgery. That may be coincidence, and some of them are out a few years, but wait some time and that may not be true. So none of these have been studied, but they're done, at least in the United States. Patients with chronic pain are oftentimes offered surgical procedures, and the one that I'm going to talk about for the rest of the talk is total pancreatectomy with autocell islet autotransplant. So we do them in Pittsburgh. But we haven't done. We're a relatively new program. We just started doing them. We've done about 15 children. The largest series is from the University of Minnesota. And so I'm going to go through this. So the rest of this is really going to be a journal club. as I talk about what their data is. And I think the couple people I want to mention on this group are Sarah Jane Schwarzenberg, who's a pediatric gastroenterologist who's worked with the program for a number of years, is quite knowledgeable, and Malena Belen, who's actually a pediatric endocrinologist who was at the American Pancreatitis Association meetings in Hawaii and participates, and she's actually discovered that the exocrine of pancreas is important too, although her main focus is on endocrine dysfunction and the role of the islets in the transplantation. But she's a young person that I think people will hear a lot more from over the years. So they reported on 484, they had 484 total pancreatectomy and islet cell transplants from 1998 to 2012. 75 were in children. Of these, 27 were young children between 5 and 12, 48 between 13 and 19. A little more female, but pretty even. And about 50% were hereditary in that they either had PRSS1 mutations or they had a family history of chronic pancreatitis without a known mutation. So their experience was also that a number of these kids had PRSS1 mutations. There were surgical complications, and I'm not going to go through this carefully, but there were in about 20%, and there were the things that you usually think about with major abdominal surgeries, bleeding, anastomotic leaks, abscesses, infections, and obstructions. And of interest, I think, is that the number of complications in the younger age it was only 7.4% compared to the older children. So the young children actually did pretty well with the surgery. They went through it and not a problem. There was one death. This was actually one of my patients from a while ago, that a child that had multi-system diseases and was very sick to begin with. So when you look at the endpoints that they used, one was pain. One can see, if you look at the prevalence of narcotic use by years after the total pancreatectomy, you can see that the use went down, but it doesn't go down to zero in kids. And this is the same thing that we see in that they saw in adults. So there's still some people who have persistent pain that require narcotics. And if you look at what they defined as pancreatitis pain as opposed to any pain and pain severity, once again, they saw a large improvement. A number of the patients still had the pain, though. So it's between 10 and 20% continue to have pain that can be chronic or episodic, and sometimes the same pain that they had before. This isn't as high as they saw in adults, but it still can occur. But many of the kids had an improvement in pain. In the 15 we've done in Pittsburgh, they've all had improvement in their pain and actually haven't. Insulin independence is actually a goal. And one can say that this is the months from the total pancreatectomy and islet cell transplant, and the number of patients, percent of patients that are insulin independent, meaning they're off insulin. Obviously, in the postoperative period, it takes a while for the islets to begin to function, and everybody needs insulin for a period of time. In children, they get up to about 40% that are insulin independent. The remainder of the bulk of them requires lower doses of insulin, and around 10% or so of the kids are full-blown diabetics. Younger children appear to do better. So if you look at insulin dependence at 5 to 12 years, it was 56%, and at 13 to 19 it was about 40%, but one can see this is fairly short follow-up, particularly in the younger group. And that's also a problem when you look at the overall group. So it appears that the insulin dependence is fairly durable, but this is only 3 years. They had one patient that was out 10 years. They have an adult that's, I think, 25 or 26 years. But the failure rate is actually fairly high. It's probably 1 to 2% per year, maybe a little higher than that in the adults. We don't know what it is in children. But over the first 3 years, it was fairly durable, although you can see there is a loss. There are 3 factors associated with a higher probability of insulin independence. That would include male sex, lower body surface area, and total islet equivalents transplanted. So the more islets you can give per kilo, the better the patients seem to do. Quality of life, it makes, I think, a fairly big difference. This is something that Malena Belen's quite interested in. And so that if you look at the measures of physical and mental competence surveys at time after TP-AIT, they all get better with time. The percentage of parents that report the child's condition prevents them from attending school by the time after TP-IAT. Before the TP-IAT, most of them had trouble attending school, and that gradually gets better over time. And that's been our experience as well. The quality of life of these kids becomes much better. Now, whether that's going to be a durable response remains to be seen. So, in summary, familiar genetic risk factors are probably the most common etiology of chronic pancreatitis in children, and children with chronic pancreatitis undergo TP-AIT for the same indications of adults. It's really quality of life, and pain is what's driving that to the larger extent. And the adults that come to TP-AIT, many of them are on chronic narcotics, which and it may have something to do with the fact that about 20% of them have the same pain after the total pancreatectomy that they did afterwards. Children tolerate the procedure well. Insulin independence is better at 1 year in patients younger than 12 years. Not sure about durability. Quality of life improves. So that leaves the question, is total pancreatectomy and auto islet cell transplant the right therapy in children with a lifetime ahead of them? We don't know the answer to that. It makes me nervous. I am, by nature, somebody who doesn't like to do things that are irreversible. And I worry about this every time I talk to families. When I counsel families about the surgery, I just talk about the surgery. I don't encourage them one way or the other. They need to make this decision. But it's a very difficult decision. We know nothing about long-term outcome data in children after TP-AIT. What we need to learn. We need to learn more about the natural history of chronic pancreatitis in children. One of the arguments that was made recently against TP-IAT is that 60% of these kids are on insulin afterwards. Whereas if you look at the curves, I forget which one of this same graph appears in two different papers, so I forget which one I took this from. But anyway, what you can see is with PRSS1 mutations and ones that were negative for PRSS1, that you look at the time to diabetes mellitus over age, you can see that around 10 years of age, you start to see some diabetes. It can occur before then, but the progression is fairly slow. Now, one could argue that over a lifetime, the kids that we see have a very high risk of developing diabetes, but we don't know. And we don't know whether the kids we're selecting for the operation are down here or they're going to be up here. We have no idea, not a clue. We need to define the pathophysiology of chronic pancreatitis. Genetic disorders has already been mentioned. There may be the opportunity to develop novel therapies where we can treat these kids and prevent this. We need to understand the process of fibrosis, and are there ways to reverse this? This has been a focus in the liver community for a long time. People in pancreas are starting to think about it. Regeneration. It turns out that the pancreas does have some capacity to regenerate. Can we take advantage of that? Can we stimulate it? Are there ways to do that? And I think we also need better approaches to treating pancreatic pain, because that's the driver for this operation. And if we can do a better job of treating the pain, giving the kids quality of life back, will they do better? Will they not need an operation like this? So we still need to know how to predict who will need the operation. I hope it's nobody in the future. How to predict the best time to proceed. We don't have any models that can forecast rapidity of progressions. If we knew that, if we knew when you were going to get diabetes or when you were going to get pancreatic insufficiency, and we have better ways to treat pain, some patients may decide to work with the pain and wait. We don't know how to identify the optimal time to harvest islets. Clearly, the more islets you get, the better the outcome, but we don't understand. I mean, most of the patients that we do still have a normal mixed meal tolerance test, but we still get a variation in the islet isolation. How to improve rates of insulin independence. We're going to promote length of islet survival and function. We know that the islets don't live forever in everybody. In some patients, they have long-lived, others, they disappear quickly. We don't know what to do about that. We don't know how to keep them alive in the liver, which is where they're currently placed. Ways to promote islet growth and expansion. So can we learn how to regenerate the islets once they've been transplanted? Whoops. I guess I didn't have the last slide that I wanted in there. But I think the message is that we're doing this as, I think it's a desperate measure. It needs to be thought of carefully. And I think our goal should be to put the surgeons out of business for this operation. Thank you.
Thank you very much for a nice presentation. It was a little bit shocking. It's really a huge number of children with total pancreatectomy. So like a gastroenterologist, I prefer to prevent this stage.
Yes.
But very nice work and very nice results. So is there
and it's going. I think, David, you told me yesterday that there were 20 centers in the U.S. now doing this? Yeah. So there's been an explosion of growth. Yes?
Yeah, thank you very much for this nice talk. I mean, this operation is quite a life-changing event for all these patients. And I just wanted to ask you how long, in average, the consideration to proceed to this operation takes you with the children?
Well, a lot of the patients that we've done have come from other areas, and they come to us, and the families are the ones that are looking for the operation. It varies. I don't know the average length of time between when they first come and get done. I think in Minnesota it tends to be fairly quick. The decision at most places, including Pittsburgh, is made by a committee, so which includes adult gastroenterologists, pediatric gastroenterologist, adult and pediatric endocrinologist, pathologists, surgeons, social workers, a psychologist. And we discuss the patients and make a determination whether to offer it to them.
But somehow it's quite difficult for you to get a real feeling how this disease course in these patients is, because you have just a short time period to talk to these patients. And then you offer a really
well, most patients already know. I mean, most families that come interested in this know about it, yeah, and have done some research and have and talked about it. But yeah, we do it, and multiple people talk to them. I mean, in their visit, a family with a child comes, I would see them, the surgeons would see them, the endocrinologist see them, the psychologist sees them, social worker sees them.
So it's difficult in the end.
Yeah.
Thanks.
Nicholas.
Mark, how does cancer risk factor into the decision?
We don't use that with the kids, and I don't think they use it. Most places don't use it in adults. I think there obviously is a risk. I think that risk is decreasing as we learn more about other risk factors like smoking. So I don't use that, and I don't bring it up. Families sometimes ask about it, and I tell them that that's not a primary concern. And I think it can be. I do have one family in West Virginia that everybody gets pancreatic cancer in their 20s, so they're actually very concerned about it. And they do think about it. I think the other thing that gets discussed is because the islet preparations are not pure. You're putting acinar cells in. And so we have this, how many angels can dance on the head of a pin discussion about what are the risks of someone still developing pancreatic cancer after an auto islet cell transplant, and it doesn't take the risk down to zero. We know. Heiko. Oh, I'm sorry. Yep, I think you had your hand up before. Go ahead, please.
Okay, just one question. What was the reason to perform total pancreatectomy? Because we perform subtotal pancreatectomy and we don't need islet transplantation, and we've got a good results with this. Because there is not the cancer, as we're talking about the risk of the cancer, the main reason to add on risk cancer or very, very chronic pain.
Yeah, I think we'll see how long you follow those patients out. So there is literature, say, of a Pusteau in these patients, and most of them some may have a good result initially, but there's recurrence. And I think most of the kids that we're doing have genetic risk factors, and to me that's an acinar cell disease. It's not a plumbing problem. And so doing a plumbing operation doesn't make sense. Now, I'm not arguing for total pancreatectomy. I think that if we can get the kids through, but I think that right now it's probably the best surgical option we have to offer, I think. I think you're going to buy time with a partial pancreatectomy or a Pustow or other drainage procedure, but I think the odds are that it's going to reoccur.
Good ERCP experience that you can perform a lot of that ERCP and you reduce the pain. If the pain
I think you can, yeah, but there's a limit to what you can do
yes, of course.
with the ERCP, how many times you can do it, and we do that. I mean, you go and you take stones out.
Years, medium observations, 9 years without the symptoms. It's quite good.
Mm-hmm. Yeah, no, I think you do those other things, and it depends on the family. Now, the kids that we've done these on are kids who's, for whatever, who aren't going to school, who aren't doing other things. They've often had procedures done. They've had ERCPs, sphincterotomies, stents placed. There are a few that have had drainage procedures that have done, which makes it harder it makes your islet cell yield lower. That's an important question, and unfortunately, we don't really know the answer to that question. Heiko.
You say, and I enjoyed it, it makes you nervous that you don't know what will be in the future. This is the right way. If something is making me nervous, I would not do it. And I think we don't know the long-term results of total pancreatectomy and islet cell transplantation. And we can do it in adults and then see, should we do it in adolescents? But I have severe stomach ache to perform total pancreatectomy in a 5 or 6 year old child who is not able to make his own decision. And I think this has time, and we should not, I cannot understand, I think we should not do it under the age of 10 or 12, in my opinion.
Mm-hmm. Yeah, I think one could have a long ethical discussion about that issue, and it's a difficult one. And it's a situation where the family has to buy in. And typically the younger kids are kids that are not doing well at all. I mean, they're not, and I understand you don't seem to see them in Germany, but we do in the US. And they're not getting to school. They're not able to do their activities. They're on narcotics often. And I think it is a difficult decision. There's no question about it. Whether you should, one could argue either side of it, and because there's no data.
One of the things that I'm concerned about as adult gastroenterologist as well with these patients is the main indication we see is usually for pain. What we've seen is a number of patients that have minimal change pancreatitis, meaning nobody can find anything that looks like pancreatitis pain. They get their pancreas out, it's normal on histology, and they have a horrible intestinal functional disorder that comes afterwards, and the pain doesn't go away as well. But the enthusiasm to continue doing this is just irrational, and I don't know how to better control this, because it's out of control in some centers.
Yeah, no, I don't think it's like appendectomy where you're going to expect to take out a certain number of normal appendixes. You really don't want to take out a normal pancreas, and there's no question. And I think I think that's a much, having sat on the committee that goes through these, both the adults and everything, I think it's oftentimes a much bigger question in the adult population.
But the patients, there's an emotional thing where somebody says their pancreas, they just want their pancreas out.
No,
because
absolutely.
they think it's the pain, they have to have it out. They're shopping for a place to do it, and
right.
it's crazy.
And and I think if you don't think that they have pancreatic disease, you don't do that operation. You say no. Now you're right. These patients do shop, and they'll go around until they find somebody who'll do it, and that's a bad situation. I can say that the kids that we've done have all had very significant pathology. Now, whether or not,
unable to eat on TPN, long tube feedings, just can't.
Right, no, yeah, those kind of pain. But we haven't seen that yet in kids. It's a matter of time.